Very clear. We would like to start the afternoon general session. We also have an ambitious program. We have 3 pro and cons debate conversations, and we have 3 3D live in a box video presentations. Just to remind you, on the left-hand side of the room, you can have your 3D glasses. Please take one of them during entering the room, and please return it back as you're finished. We also would like to point out some information on the Twitter.
So this year we hope to encourage all of the attendees and the speakers to tweet their impressions of the meeting, and the hashtag to use is hashtag ISMICS 2017. That's all in a row with no spaces. So hashtag ISMICS 2017.
Okay. The counterpoint presentations are both presentations for 15 minutes, so about 7 minutes per presentation. I'd like to call Professor Laufer for the first presentation on sutureless valve, already the standard of care for surgical AVR. This is a pro argument.
Dear Nikos, dear Dr. Lea, ladies and gentlemen, at the beginning I would like to thank the Society for inviting me to give this talk on sutureless valves. I think the term sutureless is a little bit a misnomer. It should be stated rapid deployment valves, because sutureless per se by definition is only the Perceval valve. I want to cover, however, in my talk not only the Perceval but also the Intuity valve, which is has the same characteristic that they are both of them can be deployed rapidly into the aortic annulus. Now this is our hospital where I'm working. These 2 towers in the center of the city is well known as the Vienna General Hospital, one of the largest hospitals in Europe. And if we now look on our options for the treatment of aortic valve disease and the progress we should make in order to have surgical aortic valve replacement remaining the gold standard and being better or getting better compared to transvascular technologies, we have, I would say we have 2 approaches. The first is we should take the opportunity to use new surgical prosthesis technology, and here in particular, and I will talk about take the pro position for sutureless and rapid deployment valves. But also, of course, and I think the con speaker will address that topic, that there's also a progress on the next generation of standard bioprosthesis. And we also have to use more minimal invasive access surgery than it is done now. So I wanted to show you these 2 types of prostheses. I think they are very well known to you. This is the first one is the Intuity. It's actually not a sutureless valve because it needs 3 nadir stitches which are tied down at the end of the implantation procedure, and the seating and the sealing is done by inflation of a stent which is covered by a fabric. The second one, which is a real sutureless valve, is the Perceval valve. That is a self-expanding valve. However, you can use also a balloon to accomplish a perfect seating of the valve, and that is certainly a matter of concern if we come to the issue of conduction disturbances. Now, what are the problems? What are the opportunities and the advantages of these rapid deployment valves over standard surgical aortic valve prosthesis? First of all, it's the shortened implant time that translates in shortened cardiopulmonary bypass time, as well as in shortening of crossclamp times. And as you see here from the Triton study, which was the CE mark trial of the Intuity valve, there's an almost 50% reduction of the crossclamp time for isolated AVR as well as for combined AVR and CABG. If you look on the cardiopulmonary bypass time, it's an about almost 40% reduction compared to standard values which have been taken from the big STS database. So it was not a direct comparison with either a propensity-matched cohort or a randomized cohort, but the cohort where these data were compared with are represented by the STS database. So very dramatic decrease of cross-clamp time and bypass time. If we look now on the same variables, for the Perceval, this is a study that was recently published in the European journal by the group from Cavalieri. And you see here that we have a reduction in cardiopulmonary bypass time compared to patients who received a standard surgical valve. It's highly significant, and even more or even higher significant is the reduction in cross-clamp time with this type of rapid deployment or this sutureless valve, which is also highly significant. And that was, these are very impressive data. Likewise, if you look now in a multi-center registry, which is the CAVALIER registry, what was the CAVALIER study, you have here also a very impressive reduction in the cross-clamp time for isolated AVR, as well as with the combined procedures. When you, of course, when you compare that what is published in the STS database, this study had no comparator, so it is in comparison to the STS. So what are now the benefits of these reductions in cross-clamp times and in bypass times? There are two which we can follow based on some considerations. First of all, we will be able to do more procedures because of this easier mode of implantation. We can do more procedures, not with this golden standard approach, but with the upper hemisternotomy in the different variants, with a lateral parasternal, of course, which is not done anymore, I think, but most importantly, with a right anterior thoracotomy approach, which is, at least to my opinion, the best and the least invasive approach for a surgical aortic valve replacement. Now, this is the situation. In this case, you see a direct aortic cannulation and a direct venous cannulation, so we do not touch the groin to be away from any problems arising from the groin. And you can do that with a 7 centimeter skin incision. And with this limited approach, it's about 30 minutes of cross-clamp time difference between a standard surgical valve and a rapid deployment or sutureless valve. So this is one of the evident benefits. But also there could be some influence on mortality because of shortening bypass time and cross-clamp time. And as you see here from the Triton study, we have a 1.7 all-cause mortality after 30 days. And if you look in the Transform study, which has more than 800 patients, which was the market release trial for the US market, you see there is a very impressive 0.8% 30-day mortality. And this is these very favorable data might be related to this shortening of cross-clamp time and bypass times. I say might be related. But there are other differences and there are other advantages in favor of sutureless valves. And they are very evident if you look on these two pictures. On the left side, the conventionally implanted with foreign material, there with platelets that might be susceptible to endocarditis, to bacteria, obstruction of the outflow tract to a different degree, whereas on the right side you see the Intuity in place and where all these type of problems will not arise. So we ask, can that be proven from the data, from the studies we have up to now? And you see here, these are standard valves, and the mean values of the mean gradient across the valve are usually in the mid-10s or in the high 10s, the values, especially in the valve sizes 23 and smaller. They're a little bit lower, of course, in 25, 27 sizes. But now, if we look on, for example, the Triton valve, and that was published in the GTCVS out from the Triton trial where we participated, you see that after 3 months, the mean value for all the valve sizes, the mean value is a single digit, a high single digit number, and this is at rest, this is a hemodynamic at rest. Nobody has systematically tested these new valves and compared them to standard valves under exercise condition, which is very important if you go in low-risk patients or intermediate-risk patients, implant this valve who do exercise. So at the resting hemodynamics, we have a mean gradient, a mean value of the mean gradient in the high single-digit number. How does it compare to the native aortic valve? And if you look, for example, to the Ross operation, this has nothing to do, of course, with the topic, but just to know that these leaflets, they are stained, they are impregnated with glutaraldehyde. These are not native leaflets. There is some rigidity of the tissue against the blood flow, so we have about a mean value of 3 if you look on the Ross operation. But there are other advantages that are related to this low gradient. If you look on the patient prosthesis mismatch, you see here severe PPM, which is clinically will be clinically relevant. And you see here in the surgical data, we have about 25% on the average severe patient prosthesis mismatch with conventional prosthesis. And if you look on our what our friends or what we are doing with TAVI, we have about with TAVI we have about 10%. Here is the TAVI line. We have about 10% severe PPM. So surgery is with conventional valves is inferior to TAVI, and we have to accept it, and we have to do something about it. And what can we do? We can do, of course, we can go forward to. There's a technical problem. Okay. If you use this new generation of valves, you see here on in this table, you see that the incidence of severe PPM after 1 year and the discharge is about 2 to 3% with the Intuity valve. And it is very impressive. It's much better than what is achieved by TAVI valves. And if you look on the Perceval valve, and this is once again the paper I have cited already from Cavalieri, where they made a propensity score matching between a conventional prosthesis and the Perceval prosthesis, you see also a clear advantage in effective orifice area as well as in effective orifice area index. And in this study, they published a 0% patient prosthesis mismatch. So very distinct advantages. Endocarditis related to foreign material, related to how do you handle the valve during the implantation. And the valve for implantation, the Intuity, you do not need to touch this valve with your gloves. If you use a core knot to tie down these 3 stitches, you are completely free from any contamination of the valve by your gloves. And we see we had in the long term, we had in the Triton study with 1,050 patient years of follow-up, we had an annualized rate of 0.2% per patient year of infective endocarditis. And if you look in the Transform study from the US, after 1 year with about 800 patients, they had a 0% incidence of prosthetic endocarditis. And that might be one other advantage over the standard aortic valves, where the reported incidence per patient year is between 1 and 1.2%. Yeah? If you look on the endocarditis in the TAVI, this big meta-analysis, and they published a 1.1% incidence per patient year, so it suggests also benefit compared to TAVIs. If you look on valve thrombosis, 0% in our study, in the Triton study, in the Transform study, also 0%. This phenomenon, this was gross clinical valve thrombosis. We did not look in this study on subclinical valve thrombosis. This is certainly an issue that should be investigated in the future, but also we think that there are some advantages for these new prostheses. The only question that comes, and that I will end my talk with this data because it's a hot topic, is the rate of pacemaker insertion, and that might be a little bit higher. It is in isolated cases between 5 and 6%, and then it's in the combined cases between 9 and 10%, and these are data from 3 European studies. The Transform study showed up with a higher percentage, and the Perceval, the percentage is published between 10 and 12%. So I will end my talk with the conclusion that we have documented with these new prostheses a reduced implant time and a reduced bypass time. Excellent hemodynamic performance, a low rate of severe PPM. We have a low rate of PVL. I didn't show you this data, but that is also very convincing. And we have almost no prosthetic valve endocarditis. And there is an absence of clinical valve thrombosis. We have no data on subclinical valve thrombosis so far. And the pacemaker rate, this is the only, would say, not an Achilles heel, but it's, that might be a matter of concern. And it is related to the technical aspects of the implantation. Is slightly elevated. And we have in these trials a very low early mortality and excellent objective performance criteria and hemodynamic performance when we compare these prostheses with sAVR and with TAVI. And of course, these are traits, these are very specific characteristics that will translate in the broader use of minimal invasive techniques. Thank you very much.